KEYNOTE-412 was one of the large Phase III trials that looked at the question of whether or not immune checkpoint inhibition could improve survival when added to definitive chemoradiation. And I think it had some advantages over some of the other studies that had been reported out as being negative. One was that it was a very large study, so it seemed like it was adequately powered. And another was that it used a PD-1 inhibitor, which was a validated agent that had already been shown in recurrent metastatic disease to improve survival, as opposed to some of the other studies that use PD-L1 inhibitors that have not entered the standard of care in head and neck cancer. But KEYNOTE-412 was negative, and it was pembrolizumab did add numerically in terms of disease control, event-free survival, overall survival, but it did not meet the prior statistical hypotheses, and it was not judged to be a positive trial. With longer follow-up, the curves have continued to separate, and so the 5-year follow-up data have previously been presented. But one of the quirks of the KEYNOTE-412 trial was that it did accept patients who had, first of all, a variety of sort of prognoses or risk of recurrence. So there were both HPV negative and HPV-associated cancers included, and it included stage 3 and stage 4 patients, and then it included both those patients whose tumors express PD-L1, where we expect pembrolizumab to work, and those where the tumor did not express PD-L1, where maybe we don't expect pembrolizumab to work. So what we did here was, with the long-term follow-up, we now did a subgroup analysis focused on the PD-L1-rich tumors, those with a combined positive score for PD-L1 of 10 or higher. And what we found here was that it looked like pembrolizumab was delivering quite a significant advantage, 12% difference in 5-year event-free survival, 10% difference in 5-year overall survival, and in both cases, although these were unplanned subset analyses and we don't have p-values, the confidence intervals were under 1. So I think the question here is, did the quirks of the design of 412 end up not delivering an answer, even though pembrolizumab is benefiting higher risk patients with PD-L1 expressing cancer? So if we looked at the HPV-associated cancers, the hazard ratios were around 1. If we looked at the stage 3s, not much benefit, but a pretty impressive benefit for the CPS-10, probably concentrated in the HPV-negative higher stage patients. So I think the question is whether these data will be accepted by NCCN or ESMO guideline committees as something to discuss with patients who have high-risk disease and high PD-L1 expression, because it looks as if there might be something like a 10% survival advantage, and we wouldn't want to withhold that from patients.